Welcome to AETCM, the Emergency Medicine Channel. A 54-year-old male presented to the ER with complaints of heaviness of chest since 6 hours. On our initial 10-second assessment, patient was conscious and oriented. Coming to primary survey, airway was patent. Coming to breathing, respiratory rate of 25 per minute, saturation of 97% in room air. Coming to circulation, at this point of time, the patient was connected to a defibrillator and the BP record was 130/80 millimeters of mercury. Two large bore IV cannulas were inserted during this point of time. Coming to disability, GCS of 15/15, moving all four limbs. Coming to exposure, temperature of 99.2 degree Fahrenheit, GRBS of 140 milligram per deciliter. Coming to adjuncts of primary survey, an ECG was taken at this point of time, which showed a heart rate of 54 beats per minute with a bundle branch block and also 2:1 AV block. Coming to
So when you are talking about the ECG, first you will have to confirm the patient identity. Confirm the patient identity. Then you need to tell that first this is the ECG of this 55-year-old male patient named this one. Then we will have to tell about the standardization. So in that ECG, you are able to see the standardization, the side one rectangle shape. So that is normal standardization. After mentioning this, then we will go to the rate. So rate you will have to mention. Then rhythm, is it regular or irregular? So rate, what was the rate?
Rate was 50 to 60 beats per minute.
Okay. So if it is less than 60, bradycardia. So bradycardia is there.
Then coming to the
is
rhythm.
Is it rhythm?
Rhythm, the patient on seeing the ECG, first the P is followed by QRS, but intermittent we can see like that there is P which is not followed by QRS, which shows there is some block or the AV node has not been transmitting the impulses.
Okay. So this patient, this is actually a confusing ECG. This looks like there is a fixed PR interval and PR interval is fixed, but in between some P's are not getting conducted. And the PP interval and RR interval are also equal. So we can call it as a third degree heart block, or according to, but when we look at the ECG initially, it can be mistaken as a Mobitz type 2 also. It looks like more Mobitz type 2 and complete heart block. And we can see that every alternating P is not getting conducted. So it is 2:1 AV block is also there. Then that is rate, rhythm. Then we will be talking about the axis. What is the axis?
Axis, when we look at the QRS complex, AVR is having a tall QRS. Then lead 2 is also having a 1 and 2 is having approximately same height of QRS.
Mainly we will be looking at the 1 and AVL. In this we won't be able to get the axis properly. So, but when we are telling a ECG in normal scenario, we will be confirming the age and identity, standardization, rate, rhythm, then axis. Then we will be starting from P wave, then PR interval, QRS complex, T, ST segment, then T. Okay. So this patient after axis will then move to P. How is the P? Morphologically?
Morphologically, height and breadth is less than 2.5 boxes, so approximately normal P wave. But each P is also followed by QRS, but the second P is not followed by a QRS.
So it is not, okay. Then PR?
Via PR segment is normal, less 3 to 5 boxes is there, but the QRS is wide. Showing a bundle branch block.
Okay. Right bundle branch block. So in the V1 you can see the RSR pattern. So our bundle branch block is also there. Then ST segment.
ST segment also appears to be normal. No elevation of J point anything is.
Then T.
T wave is also appears to be normal.
So this is how you describe the ECG. In between that, after telling standardization, you can mention the speed and everything, speed normal, these things also you can mention. Okay. So what is the impression from this ECG? After explaining all this, we will talk about the impression. So we have already told that there is one looking like Mobitz type 2 or complete heart block picture is there. Along with that, a bundle branch block is there. So what is bifascicular block, trifascicular block and all?
right bundle branch block with a leftward axis is a bifascicular block. If the right bundle branch block with leftward axis with a fixed PR interval, that comes a trifascicular block. LBBB itself makes a bifascicular block.
Okay. So this patient is having a bundle branch block. Along with that, there is a heart block also. So we can tell it as a trifascicular block can also be there for this patient. Okay. Okay. Then what did you do?
Then we went with the ample history.
So before going to ample history, we need to determine this patient is in bradycardia. This patient had history of chest pain also. Is he having pain at present?
No, at present the patient is symptomatically better and does not complain of any other symptoms.
Okay. So should we, what should we do? So in the, according to ACLS, what should be done in this patient?
Initially, we have to we check the airway. We have, if hypoxia is there, oxygen has to be given. Cardiac monitors are corrected. IV cannulas are also being inserted. Then persistent taken, and persistent bradycardia is there. So we ask for other symptoms like symptoms of hypertension, altered mental status.
Hypertension is not there. BP was normal.
No altered mental status, no ischemic chest discomfort at present, no signs of any shock, no other acute heart failure features, no Krebs, nothing were there, no pedal edema were not there. So we just, since this is not there, we just monitor the patient and observe the patient.
Okay, that is according to your AHA bradycardia algorithm. But according to UK guidelines, they tell that if at all the patient had a recent asystole, 4 things are there. These things are same itself, but if the patient had a recent asystole, or the patient is having Mopitz type 2 block, or the patient is having a complete heart block with a bundle branch block. So this is actually Mopitz type 2 and complete heart block with bundle branch block, or a ventricular pause more than 3 seconds. So asystole, ventricular pause more than 3 seconds, a complete heart block with bundle branch block, or a Mopitz type 2. This should be considered as unstable and you can try atropine. But even though we try with atropine, there might not be much effect. So this patient will directly go for a pacemaker implantation. Okay. Okay. So this patient at present you are monitoring and observing. Suppose this any unstable features come to the patient, what will you do?
Initially, we have to go with an atropine 1 mg bolus. Maximum we can give up to 3 mg. Then we will wait and observe whether the heart rate is improving or not. Then
how frequently will you repeat atropine?
We can give every 2 to 3 minutes.
Same as that for adrenaline and cardiac arrest, 3 to 5 minutes you can repeat. So every 5 minutes you can repeat atropine, maximum 1 mg. Suppose this is a pediatric child, what will be the dose of atropine? Pediatric bradycardia and pediatric ACLS algorithm for bradycardia and adult, the only difference is in the dose. Bradycardia algorithm, dose is 0.02 mg per kg. Okay. And one more difference is there. Pediatric, if heart rate is less than 60, it is considered as cardiac arrest. Okay. Okay. So atropine, even if it is not responding to atropine, what will you do?
We can start on dopamine or adrenaline can be started.
Dose?
Dopamine can be started at 5 to 20 microgram per kilogram. Can be started. Adrenaline also 2 to 10 microgram per minute can also be started.
Then if not responding to that also?
Then we need to plan for transcutaneous pacing.
So how will you do that?
There are temporary and permanent cutaneous pacing is there. Temporary can be transcutaneous, transvenous, epicardial, and also transesophageal pacing is there.
Okay.
Permanent, we will plan for an expert consultation and when with people.
In our ED, we will be having only transcutaneous pacing facility. So for that, we can, where will you shock if a patient is in, if you are planning to do synchronized cardioversion and when you are planning to do defibrillate and all, where will you shock? Below the right clavicle and the apex. So either you can keep the paddles, not the paddles will be used for shock. We have the adhesive paddles. That adhesive paddles can be applied onto the patient because we cannot use that defibrillator machine on the patient because somebody has to keep it on the patient continuously. So this we need adhesive paddles to initiate transcutaneous pace. So adhesive paddles should be attached either on the below the right clavicle and the apex, or you can keep it anterior posteriorly. One can be kept anteriorly at the apex and other one can be kept between the left side, between the scapula and the midline. That should be kept. Between the scapula means just lower down scapula, okay, or just below the scapula and the midline you can keep it. So that is andro-posterior position. And how to do this? So this is like we will be giving, we are actually overtaking the heart's beat. The heart is beating in a bradycardia, and this is causing the patient to be unstable. There will be hypotension, there can be altered mental status and all. So first we have to take the consent from the patient and bystander, tell that we are going to initiate transcutaneous pacing. So for transcutaneous pacing, we will have to give some little bit of a milliamperes of little bit of shock will be going on for this patient. So patient will be having pain. So we need to explain that we need to take consent. Then we will have to give a small dose of procedural sedation or small analgesic should be given. Then we have to set the heart rate. So if this patient's heart rate is only 40, we need a minimum of 60 or 70. Then we need to set the heart rate of that. So if we are setting it as 70, set the heart rate as 70. Then we will have to select the current to be given. So initially you can start as 30 milliamperes and see. And we will be seeing whether capture is there. Capture is there means you will be able to see the spikes, electrical spikes going on, and you will be seeing the patient's heartbeat, QRS complex also. And if initially there might not be any capture, after some time we'll have to increase the dose by, but if it is initially we started with 30 milliamperes, you can increase to 40 milliamperes. Like that we have to increase till the patient will get an electrical capture. Capture means that we will be seeing a spike followed by QRS, spike, QRS. That means there will not be a irregularity. Spike, if it is not capturing, the spike and the QRS complex will be going in its own fashion. But once it is spaced, then we can say that patient is having a spike followed by QRS, spike, QRS, spike, QRS. That means patient, the monitor, the defibrillator has overtaken patient's normal heartbeat. That means this bradycardia rhythm, and the shock is being delivered correctly and the patient is capturing electrically. That is electrical capture. And after electrical capture, we will be continuously observing the patient. And if this patient's GCS is improving or BP is improving, chest pain improves, at cardiac failure pitches, everything subside, that is called as mechanical capture. That means the body has mechanically improved because of this improved heart rate that we have given from outside. This is transcutaneous pacing. But that is only a temporary measure. We need a permanent measure by inserting a permanent pacemaker implantation after expert cardiology opinion. Okay.
Then we went with the amble history. Amble history, the patient was having this heaviness of chest since 6 hours, but there was no other associated symptoms, no chest pain, no palpitations, no signs of any heart failure, no altered mental status, no ischemic chest discomfort. No history of any allergies, no history of any similar episodes in the past. The patient was currently not on any medications. Systemic examination was also no pallor, no crest, cyanosis, clubbing, or lymphadenopathy. CVS examination, JBP was not elevated. S1 was 2 present and no murmurs. Other systems was also within normal limits. So we just monitor and observe the patient, and we get a cardiology opinion, and the patient was shifted to CCU, and right now planning for permanent pacemaker implantation.
Amble history, one important history is which one? Drug history. What all drug history should we ask?
Any beta blockers, calcium channel blockers, digoxin, and all.
Then other drugs, these we will be usually discussing about toxicity. But some medicines which we miss is amiodarone. Patient might be taking amiodarone. Then clonidine. Clonidine is centrally alpha agonist, so clonidine can cause. Then in overdoses like opioid overdose also there can be bradycardia. Okay, so this patient was stable in our ER, even though according to UK guidelines, patients that thing fits into unstable. In the ER, patient was stable, so we managed according to the HA algorithm, and since patient was stable, we monitored and observed, and we shifted to the CCU. Okay, can you tell what are the types of heart blocks?
Heart blocks can be basically divided into 3. First degree heart block, second degree, and third degree heart block. In first degree heart block, every impulses from the SI node is transmitted to the ventricle through the AV node but there is a delayed impulse. But every impulse is being conducted. So there is a prolonged PR interval.
What is normal PR interval?
Normal PR interval is 0.1 to 2.2.
0.12 to 0.2 or 120 to 200 milliseconds. Okay. In this patient, it was 180, so it was normal.
Then come to second degree heart block. It can be further divided as AV block or Mobitz blocks, type 1 and 2. To fit the criteria of Mobitz blocks, there at a point of time, one impulse should not be transmitted and two or more impulses should be transmitted. That means two or more P waves followed by a QRS complex, and at that point of time, one P should not be followed by a QRS complex, which can be further divided as Mobitz type 1 and Mobitz type 2. In Mobitz type 1, the PR interval get prolonged. Initially, it is like if we take it as X, then gradually 2X, 3X, and finally an impulse that P is not followed by QRS.
That means that P will not be getting conducted. So PR, progressive prolongation of the PR interval will be there, and at one point P will not be conducted. Then after that, the same thing will repeat.
In Mobitz type 2, the PR interval is constant and intermittently.
It can be either normal or prolonged, but it will be fixed.
If it does not fit into the Mobitz criteria, then we will look at the AV.
But one more thing is there, complete the Mobitz type 2.
Mobitz type 2, fixed PR interval, and 2 or 3 normal PR intervals are there, then the P wave is not followed by a QRS.
In between, some P wave will not be followed by QRS. So depending on the that we will be deciding what ratio it is not getting conducted. So in a fixed ratio, the P's will not be conducted. Okay.
Then it does not fit in the Mobitz criteria. Then we think about AV block, which is second degree. In AV block, there is intermittent transmission of the impulses. Like it can be fixed or variable. If fixed, then 2:1 block, then that means every 2 P waves, one is transmitted and one is not transmitted. That is, one is followed by a QRS, one is not followed by a QRS, but the PR interval remains the same.
That is for this patient.
And we come to complete heart block. In complete heart block, the SA node transmits the impulse but does not travel through the AV node. No impulses from the atria has been transmitted to the ventricle. As a result, the other parts will take over the activity, like in junctional rhythm or atrioventricular rhythm, like that. In that case, the QRS complex can be produced with junctional rhythm. The QRS complexes are formed, but no P waves are seen as such. SA node transmit the impulse to the atria, but P waves are seen regularly, and the junctional rhythm produced by the ventricle as such, or the junction, will be independent. Both are independent, so there is no association between atria and the ventricles.
Okay. So since you have talked about junctional rhythm, so what is the normal pacemaker rate, SA node rate?
100. Due to vagal tone, it is decreased to 62.
So somewhat around 60 to 100. So if it is coming from junction, what will be the rate?
40 to 60.
If that junction is also not working, then it will be ventricular rhythm. What will be the rhythm rate?
Ventricular also, it can be two types, idioventricular or accelerated ventricular rhythm can be there. Based on that, it can be range from 40 to 60 and 60 to 100 can also be.
Thing is, junctional, there can be accelerated junctional rhythm and there can be junctional tachycardia. So if the patient is in junctional rhythm, heart rate will be around 40 to 60. If it is accelerated junctional rhythm, it can be more than 60. Like it will be like a normal heart rate, more than 60. If it is like junctional tachycardia, heart rate will be more than 100. Understood? So junctional rhythm is there. That is the normal junction rhythm of the junction. Then accelerated junctional rhythm, that will be looking like a normal rhythm between some 70 to 100, and junctional tachycardia, that will be more than 100. Okay. What is sinus arrest?
Sinus arrest means every P wave is followed by a QRS complex. Suddenly, there is no P wave.
No P wave. That means SA node is not initiating on a P wave. So for what duration? What is the minimum duration required? If I say one P wave is not coming for more than 3 seconds, that is called as a sinus arrest. So this patient is having a high tendency for a asystolic cardiac arrest, risk is very much high. Okay, so we have talked about the blocks. In this blocks, which are regular, which are irregular. We usually in tachycardia we will be telling regular, irregular. Which all are regular? It is not clinically significant, but which all are regular, which all are
Mobitz type 2 is regular.
regular. Regular means RR interval
Interval
should be
should be
equal.
equal.
Mobitz type 2 in between RR is getting missed. QRS is missed, no?
Type 3 is regular.
Simple thing, sinus
Complete
bradycardia
bradycardia.
is regular. Then first
Degree heart block is regular.
Ah.
And then
first degree heart block is regular. Then one more is there, if the patient is a known case of AF and the patient is developing complete heart block, then it will be somewhat looking like, in that it will be looking like a third degree heart block. But P wave won't be seen. Fibrillatory waves will be seen, but the RR will be regular. Understood? Understood? Complete P wave won't be seen. Fibrillatory waves will be seen. But usually what will happen in AF, RR will be irregular. But if there is complete heart block, RR will be regular. Okay. That is there. Then junctional rhythm can also be regular. Then irregular?
Still Mobitz type 1.
Mobitz type 1 and type 2. Then
complete heart block.
Complete heart block is?
Regular.
Regular. Then?
Variable second degree heart block.
Variable second degree heart block. All the second degree heart blocks along with AF with the controlled ventricular rate or slow ventricular rate. These are irregular. Okay. Okay, so in our ER, in a patient, if a patient is coming with bradycardia, our role is to determine whether patient is stable, unstable. Along with that, we can see for the reversible causes. As we discussed about the reversible cause of cardiac arrest, we need to check for the reversible causes in bradycardia also. What all it can be?
Hyperkalemia.
Most commonly, first you talk about physiological causes. Physiological causes of bradycardia. In ICU, when you see patient in bradycardia? Sleeping. Then? Physiological causes, very physiological causes. Athletes, secondary to some vagal stimulation, these things can cause physiological bradycardia. Then pathological bradycardia?
Hyperkalemia.
Pathological can be divided into cardiac, non-cardiac. So first we will discuss about cardiac. Cardiac causes of bradycardia can be?
Cardiomyopathy.
Cardiomyopathy. Then? Heart blocks. MI. Which MI?
Inferior MI.
Mainly involving the right coronary artery, because right coronary artery is the one supplying the SA node, AV node and all. So if that is getting affected, patient will have bradycardia. Then cardiomyopathy, myocarditis and all can cause bradycardia. That is cardiac causes. Then non-cardiac causes.
Hyperkalemia.
We can start with the D. So we have discussed about cardiac causes. D for drugs.
Beta blockers, calcium channel blockers, digoxins, amiodarone.
Clonidine. Then suppose a patient is coming to us with a beta blocker overdose, and you know it is beta blocker overdose and patient is having bradycardia. What will you give first, atropine or glucagon?
Glucagon.
Yeah. First you need to manage according to algorithm. First you can give atropine, then you can give glucagon. Okay. So drugs we had. So C for cardiac, D for drugs. Then E, electrolytes. Electrolytes as you saw, hyperkalemia. Then F. F is difficult. F is like something like an infiltrative cause, like sarcoidosis, amyloidosis. These things can cause conduction problem, and this thing can cause bradycardia. G. G is actually a clue only. G is for GCS. If GCS is low, what will happen? When will a GCS be low?
IC bleed.
IC bleed. IC bleed, there will be
Cushing's
syndrome, raised ICP. So that can cause bradycardia. Then H. Hypoxia.
Hyperthyroidism.
Hyperthyroidism.
Tachycardia.
Hyperthyroidism, tachycardia. Hypothyroidism. Then hypothermia. 3 H's are there. Then last one, HI. Infections can be there. Mostly infections like some Lyme's disease, typhoid, some infections can also cause bradycardia. So these are the causes of bradycardia. Okay. Anything else? Thank you.